ahead and see it.
Okay. Good evening. My name is Jim, and I'm one of the clinical facilitators here at Cancer Support Community in Cincinnati. We are one of over 50 affiliates of a national network that provides social and emotional support for anyone impacted by cancer. So thank you for virtually joining us for our prostate education group this evening. This education meeting on Wednesday of the month from 7 to 9 p.m. Eastern Time. Here at Cancer Support Community, we provide healthy lifestyle classes, social opportunities, and educational programs like this one tonight to anyone impacted by cancer. In addition, we offer support and networking groups to give and to get support. In addition to the education group, we also offer a local
testing my audio.
A local prostate cancer networking group for people living with prostate cancer, both in Ohio and Kentucky. The group is a hybrid offering, meaning you can attend in person at Blue Ash here or over Zoom on the second Wednesday of each month from 7 to 9 p.m. Eastern Time. So to learn more about our service and find the Zoom links for the group or any of the other programs, please visit our website at mycancersupportcommunity.org or call us at 513-791-4060. And before we get to the main presentation and to our speaker, there are a few important housekeeping issues that I would like to cover. Everyone has been placed on mute for the duration of the program to cut down on background noise and allow everyone a chance to hear the speaker. Please make sure you are identified correctly for attendance purposes. If your full name does not show up under your picture, please use the chat button on the bottom middle of your screen and choose my name from the drop-down box to send me your correct name. You should also know that we are recording this program, and we're doing so for future use and to make sure everyone has access to this program. Please know that your name and face will not be shown in the video, and we will make all possible attempts to maintain privacy. So with those messages now, I'll turn it back to Jim, who will introduce our speaker for this evening.
Okay. So everybody can hear now, is that all right? You're okay?
Yes, we can hear you, Jim.
I can hear you. Okay, good. All right, quickly, Dr. Shah is a urologist for Price Hospital. He interned at the University of Cincinnati Medical Center and then went to work in Atlanta. After 4 years of working in Atlanta, he returned to Cincinnati where he took his position at Price Hospital. He's interested in robotics, laparoscopy, and prostate surgery. Sorry about that. We enjoyed Dr. Shah's presentation to our group in 2017 and look forward to his presentation tonight. Well, thank you, Dr. Shah, for being with us tonight, and go ahead and take it.
You're most welcome. Thank you. So can you guys hear me okay?
Yeah.
Okay, wonderful. I just wanted to check one last time before we get started. Jim, I really appreciate the introduction very much. It was my pleasure to come speak with y'all several years ago. I think at that time we had talked about a whole slew of different things, but namely penile prostheses and artificial urinary sphincters. So this is kind of nice to get fielded some questions that are more on the lines of screening, diagnosis, and treatment planning. So if there's any questions that do come up, please don't hesitate to put it in the chat, and I'll try to discuss some of the answers to those questions as we're going through. Okay, so with that being said, we'll go ahead and get started. Just a little bit about me. As Jim had said, I grew up in Athens, Georgia. Huge Georgia Bulldogs fan. I'm actually going to Georgia next weekend to see the Georgia-Tennessee game, battle between first and third. So you probably won't see me next Friday. I did a 7-year bachelor's in arts and bachelor's in science degree and an MD program at UAB in Birmingham, Alabama. So I had a degree in philosophy, decided, hey, I'm going to medical school. I should probably take some biology and chemistry and organic chemistry and physics classes. And I did so. And I got a BS in biology, minor chemistry, and ended up my degree there. Did my residency training at University of Cincinnati, where I finished up in 2014. I was in private practice for about 4 years down in Marietta, Georgia. And then with my lovely wife being from Cincinnati, and the fact that I was recruited back up here, I joined Christ Hospital in 2018 and have been here since. So why prostate cancer? Why do I do what I do? People always ask, usually when I'm doing vasectomies in the office, how did you get into urology? And that's exactly why I do urology. That the breadth of pathology goes anywhere from prostate cancer to bladder cancer to kidney stones to incontinence issues to erectile issues to vasectomies in the office. So it's a good mix between office and OR practice, particularly in oncology. So why prostate cancer? For me, it's a passion in helping men such as yourself, men that have either started treatment, ended treatment years ago, or in the process of making management decisions. The breadth of prostate cancer it's in left field and right field. So every man is different. That's the most important thing here, that prostate cancer is not cut and dried to where every man gets the same treatment. Every man goes down a very algorithmic sort of pathway. There's a lot of factors, as we'll kind of talk about here shortly. There's a physical and emotional component. Cancer, the word cancer, the big C, is not something that, is to be taken lightly. There's a physical component with it as it relates to side effect profiles, going to appointments, convalescence time, for instance, after surgery. And then there's also the emotional component when you hear that big C word. So I like managing both aspects of that. Then the ever-changing landscape, as you can see down here in these charts, prostate cancer can span years, decades even, and the landscape is always changing. And the time that it takes from a man to get diagnosed with some of the lower grade cancers to the time cancer, for instance, could metastasize, we'll probably have another 5 or 10 drugs out there for advanced prostate cancer. So, from the time here, of an initial diagnosis, this is sort of the area where we're talking more about localized disease, removal of the prostate, radiation therapy, CyberKnife therapy, cryoablation, focal therapy for prostate cancer, all of these sorts of things. And then we know that at some point, hopefully long after we've left this earth, but at some point, cancers do and can come back, where we institute some hormone shots to drive the PSA back down, and then flash forward 1 to 2 to 4 to 8 to 10 years, it can lead to some pretty impactful side effects and symptoms. And this is where a lot of the growth of prostate cancer research, development of new drugs, treatment modalities, imaging studies is really going. So with that being said, I received several questions, which I put in PowerPoint form, so we'll kind of go through it, about some nuances in the screening recommendations what I think of regarding the United States Preventative Service Task Force recommendations, some of the controversies, some of the pros and cons, undertreatment versus overtreatment, being sort of the main issue here. You know, on the one hand, there's this idea of not screening, and now you undertreat men. Flash forward years down the line, they start getting bone pain, blood in the urine, pelvic pain, requiring narcotics, and have you sort of missed the boat, so to speak, in terms of offering them cure, as opposed to overtreatment, where we're removing prostates too early, where men could have survived on active surveillance, or there were less aggressive treatment modalities where they would have lived just as long, or you could have just not done anything and see how they did. We'll talk a little bit about diagnosis and then a little bit about the treatment as it relates to some of the questions I received. So the first question that I had received is regarding screening: does Christ Hospital support the United States Preventative Service Task Force recommendation against across the board routine PSA testing in spite of recent findings of a rise in cases of advanced prostate cancer? So this is an excellent question that gets down to screening recommendations. I've put a copy of the United States Preventative Service Task Force recommendations here, and these were revised recommendations updated in 2018. Initially, these recommendations had said something completely different in 2012, which was don't screen anybody. And I think part of the reason they ended up revising this was they received a lot of backlash of not having any urologist on the USPSTF task force. So it was either primary care docs or PhDs or oncologists and other radiation oncologists or medical oncologists, but no urologist was on that. And so they did look at the data once again. The other thing is there was an introduction of new data from 2012 to 2018, longer term prospective trials that looked at screening protocols, et cetera, or trials that were started in the early 90s. PSA came out in 1994. So trials that may have started around that time had kind of matured 30 years down the line. And so they added some of that into those recommendations. So essentially, the old recommendations were we're overtreating, we're overscreening, don't check PSAs in men. And obviously, as a urologist, we get to see men during all aspects of prostate cancer. And I'll be the first to tell you that I came out into practice as a practicing urologist in 2014. Okay, so over the last 8 to 10 years, I have been unfortunate to see men that were not screened in light of those 2012 recommendations that have ended up having cancers that could very well have been treated, managed early, in remission, and hopefully could have extended life. Now, that being said, hindsight's always 20/20. It's hard to make those judgments that we shoulda, coulda, woulda. But at the same point, we know that we saw a slew of men that did have metastatic disease, or what we call oligometastatic disease, that went to the lymph nodes, that we're now only getting good research on to suggest that maybe localized treatment may actually help with those men. So once upon a time where we used to just give hormone shots, now that treatment paradigm has changed to a point where we can now offer pill forms, hormone shots, and radiation to still hopefully get some of those men into remission. So risk factors that are sort of that they were looking at: older age, African-American race. We do know that African-American men have an increased risk of prostate cancer, increased risk of prostate cancer-related death, and increased chance of getting prostate cancer earlier. So when we talk about screening recommendations, if you read through the details of the USPSTF recommendations, they actually say that, for instance, African-American men may benefit from early screening. Family history of prostate cancer as well is something that we look at as well. These screening modalities, we're essentially looking at PSA and digital rectal exam. I know a lot of the primary care docs are kind of getting away from digital rectal exams here, but I think that it is very important from a urologist standpoint to do a digital rectal exam. Number one, we do a lot of digital rectal exams, and we can pick up on subtleties and abnormal exams that may not necessarily translate to doing a biopsy immediately, but it may translate to us doing an MRI, for instance, which has been very well validated in the literature to be an excellent imaging modality to see whether or not biopsy must be done, or more importantly, if someone's had a prior negative biopsy, an MRI is exceptional in terms of delineating where to actually take the biopsies. So more goal-directed biopsies, more image-guided biopsies to increase the diagnostic capability. I did receive does anybody have any questions about the USPSTF task force recommendations? I guess to answer the initial question, which is, what are my thoughts on it? No man is the same. I think that I agree with part of the recommendation that says that men 55 to 69, it should be discussed. I also feel as though men with risk factors, including age, African-American race, and family history of prostate cancer, I do think that they should be screened. When to screen is up for debate. The old recommendations were every 1 to 2 years after age 50, unless you had a family member that had prostate cancer. And if that happened to be in the 50s, then the recommendation was to do it at least 5 years prior to when they were diagnosed. Of course, if that was age 50 or 51 or 52, we generally did a one-time PSA of 45. And if that number was low, then we'd decide when to do the next PSA screening, which generally would have been 50. So I do believe wholeheartedly in PSA screening. There are some caveats here. If I have a 68-year-old man with a prior PSA 10 years back of 0.5, and he's had multiple strokes and diabetes and high blood pressure and morbid obesity and multiple abdominal surgeries and hard cats or open heart surgery, those are the men that I generally say there's other bigger fish to fry. Prostate cancer is probably a little bit further down on things to sort of worry about because, as I mentioned earlier, there is that emotional aspect to it. And sometimes doing the right thing is not screening. The way that I usually explain it to men when I get referred to men for prostate cancer screening is I say, number one, what do you want out of all this, right? So I only order tests if that test is going to impact the next step, which is going to impact the next step, which is going to impact the next step, which is very well why when I see 80-year-old men in my office that are referred for a PSA, let's say a 5, I say, okay, if your PSA is elevated, would you want a biopsy? If you wanted a biopsy, would you want to know what type of cancer you were, and would you, more importantly, want to have some sort of treatment? And if the answer is, well, no, I'm 80 years old, I wouldn't want treatment, then I say you don't need the biopsy. And if you don't need the biopsy, you probably don't need to be checking the PSA, right? Because every test that we order is with the idea that we are going to use that information to guide next steps and to guide management decisions. If the answer right off the bat is, look, I'm not interested in having any sort of procedural intervention or treatment or any of those things. If my risk of dying of prostate cancer is low at age 69 or 70, then I say, well, then, are we really giving you any benefit? Now, we do know that some of these men who are 65, 67, 69, they do live till 90, right? So we're not talking about a 10-year plan anymore. We're talking about a 20 to 30-year plan. And so I do have some issue with just stopping screening at age 70. I think there are plenty of healthy men that could live to age 90 with good quality of life. That's the key, with good quality of life. And so making a blanket statement to just not screen those men, I think, is a little bit short-sighted. So the next question that I did get was in Dr. Albin's book. This is Dr. Albin actually discovered and invented the PSA test back in earlier than 1994, but it was FDA approved in 1994. He said that he wishes he had never discovered it. Any idea why he might have said this? So a little bit of background about, what Dr. Albin, what his mindset was. He published a book called The Great Prostate Hoax back in 2013. This was at a time just after those initial USPSTF recommendations had come out, claiming nobody should be, screened. The PSA test, as I mentioned, was approved in 1994. Dr. Albin's main concern was he had made this PSA test more as a test to monitor prostate cancers, not necessarily for their diagnostic sort of capabilities. You also have to realize back in the 90s, early 2000s, we were still figuring out how to use PSA as not only a diagnostic or screening, or I guess more of a screening tool, but also how to monitor it after radiation, for instance, or surgery, for instance. So, even what's changed from, who knows what my answer would have been back in 2012, 2011, in the 90s. But I can assuredly say here in, 2022, I do wish that the PSA test, was done. But I also qualify that with, it is important to know what you're using it for, how to use it, who to screen, as we've sort of talked about before. Dr. Albin's main concern at that time was he was worried about the profitability by big pharma that, hey, I've produced this test. We're checking it on every single man. We're not actually, extending the survival of these men by checking this test. We're doing a lot of unnecessary testing, unnecessary prostate biopsies, unnecessary cancer surgeries. And you got to realize back in the 90s and early 2000s, before the advent of robotic surgery, these were all open operations. These were operations that were below the belly button down to the pubic bone. You spend 4 to 6 days in the hospital. You assuredly had incontinence issues. You assuredly had a drain. You had a catheter in for maybe 10 days, 4 to 6 days in the hospital. Perhaps you had some bowels that had shut down. And so there was significant constipation, and convalescence time was significantly longer. You also had perineal prostatectomies at that time, where they were making an incision, if not in the lower abdomen, just behind the scrotum and in front of the anus, which also had its own morbidity. So something to think about. It wasn't until later when, we actually stopped screening, or some of the primary care docs stopped screening, that we started to see men with the advanced prostate cancer. And so, as I mentioned before, now that I've been in practice for 9 years, I have seen the men that I've caught prostate cancer early, and I've seen them 8 years down the line with an undetectable PSA, minimal, if any, incontinence symptoms, good erections. But also I've seen those men that, are 65 years old with metastatic castration-resistant disease, which could very well have been prevented. So it's a risk-benefit, pro versus con sort of discussion. Remember, screening is not just about preventing death. Yes, the ultimate endpoint in all of these studies is overall survival when you talk about clinically speaking. But you also have to think about the emotional and physical impact of not diagnosing prostate cancer till late. And now you're having bone pains and a PSA of 1,000 and blood in your urine and pelvic pain, narcotic usage, bowel dysfunction. So there's a lot of downstream sort of things for lack of screening that I'm not saying that all of these things would happen, but certainly something we need to think about when we're talking about whether to screen or not. Risk versus benefits. That whole idea of, are we overtreating men versus undertreating men? If you overtreat men, patients may have lived a full life without treatment or having any side effects. And that's great, but you could have also undertreated men that had slipped through the cracks, so to speak, and now they have to deal with, difficult grave disease consequences, such as, hormone replacement or hormone therapy like Lupron or Firmagon, some of those medications that can cause bone remodeling issues, osteoporosis, fatigue, breast development, weight gain, nipple tenderness, hot flashes, all of these sorts of things. So the next question is, what is my opinion on the strategy of routine PSA testing as a first step in diagnosis? Should it be confirmed by biomarker testing or MRI? So to answer this question, I do believe in PSA testing. Now, some of that is, there's a little bit of bias because I see a lot of prostate cancer patients. But as I've sort of talked about, earlier, I'm looking at not just your age. Age is only one part of the big picture here in terms of screening. I'm looking at your age. I'm looking at your family history. We know that I'm looking at race. For instance, we talked about African-American males earlier. Family history is an interesting one. If you have 3 first-degree relatives that have had prostate cancer, you may be one of the 10% of men that has some sort of genetic hereditary issue that it may pass down generation to generation. So I think genetic testing is extremely important there. Did I have a question or no? Okay. There's other factors that I look at. What is your overall health? What is your perception of your overall health? There's some men that say, I run 5 miles a day. I don't have very many medical issues. I am, I feel like I have 10 good years of quality of life left in me. And there's men that say that, but then they've had 4 blood vessels operated on in their heart. They live a relatively sedentary lifestyle. Smokers may have had some other issues like hypertension, poorly controlled diabetes, hyperlipidemia. So I look at both sides of that, not only what their overall health is, but what their perception of their health is. Life expectancy, we kind of touched on that a little bit earlier. There may be 69, 70-year-old men that have family members that have lived to 95 or 100 with good quality of life, but not just how long that they lived, but how are they living their own lives? Your dad may live to 100, but if you have a lot of medical issues and are not taking care of yourself, you may not, right? So that's only a piece of the puzzle. What is your willingness to undergo treatment? It goes back to that question I asked earlier, which was, what's the purpose of the PSA? The whole purpose of PSA is, if it's abnormal, you're going to need a biopsy. If the biopsies shows cancer that you're not a good active surveillance candidate, the recommendation is going to be treatment. If your answer was, well, I would have never wanted to be treated in the first place, do we go that route in terms of screening? And then last but not least, what side effects are you willing to put up with as it relates to treatment, right? If you're like, I'm willing to put up with erectile dysfunction, incontinence on the front end, which do improve over time, then surgery may be, something that is worthwhile for you. Or if you're like, look, erectile dysfunction is the most important thing to me, but you're willing to put up with urgency, frequency, blood in the urine or stool, some fatigue, going to get radiation treatments 5 days a week for 4 weeks or 8 weeks. Are you willing to put up with that for the benefit of maintaining your erections at least over the next 5 to 10 years? So it's a nuanced sort of discussion. I think I treat every man differently in terms of their particular circumstances. I do also want to make a point here that oftentimes when you come to the urologist, we're not starting the screening process, okay? we as a specialist have received men that have been screened, and now we are talking to them having been screened about what the next steps are. So every now and then I do have a man that comes into my office that says, hey, I've got some prostate issues. Hey, I need my PSA checked, and he's never had a PSA checked. And those are the times when I'm having those discussions with men. Unlike the typical man I see in my office who has had his primary care doctor screen him, they found an elevation or an abnormality in a PSA exam or MRI, and now they're referred over to me. So we, in a sense, most of those men, I've already kind of skipped that screening step because they were pre-screened before they came and saw me. So then a couple questions that I received about active surveillance. Regarding a positive biopsy, do you support active surveillance? And if so, for what grade groups? The follow-up question is, how are borderline decisions made? How is active surveillance carried out at Christ Hospital? And what is generally the follow-up? So I've kind of broken this down. Do I support active surveillance? Yes, absolutely, for the appropriate patients. Those three words are the key, for appropriate patients. Not all men are the same. Not all of their prostate cancer is the same. You may have Gleason 3+3 prostate cancer, but it's in 100% of the cores in 12 cores out of 12 biopsies, and you may be 50 years old, and you may not be an active surveillance candidate. In those situations, something like the Decipher test or Prolaris test, some of those epigenetic tests may be indicated, because there may be a genetic sort of predisposition to that cancer worsening, even though on paper you have only a Gleason 6 prostate cancer. But at the same point, I have some 69, 70-year-old men that have a score of 7, Gleason 3+4 prostate cancer, which technically is intermediate risk, but they may have 1 out of 12 cores that are positive. And there's an abundance of research coming out that says maybe some of those Gleason 7 low volume, low PSA men would benefit from active surveillance. Okay. So do I support active surveillance? Yes, but for the appropriate patients. And I'll kind of show you here shortly what my active surveillance guideline sort of is, the ones that I generally will follow. How are borderline decisions made? Again, we're looking at your overall health. I'm looking at your prior abdominal surgeries. I'm looking at what your wishes are. The number one factor in prostate cancer treatment is actually, what does the patient want? If you look at most categories of prostate cancer risk, surgical removal of the prostate and radiation essentially have the same cure rate. I always counsel men that I don't like throwing around words like cure. I usually say we get it in remission. Remission long enough equates to cure. Okay. But the fact of the matter is technically speaking, prostate cancer can come back at any time. Generally speaking, our benchmark is about 10 years. If it hasn't come back after a prostatectomy in 10 years, it's a pretty low risk of coming back, but it could still happen if there's any dormant cancer cells laying around. I think the first decision that should be made here is, should it be treated, right? So if I get a man with 1 out of 12 core Gleason 3+4, or a man with 1 out of 12 core Gleason 6, the question first off is, should it be treated? As opposed to a man with Gleason 6 disease, PSA of 15, and 12 out of 12 cores positive. Once upon a time, we were treating every single man who had Gleason 6 prostate cancer. Once upon a time, they either got brachytherapy Cs, they got their prostates removed, or they got radiation therapy. Yes, did we overtreat men? 100%, we did. And then we learned Gleason 6, not all those men necessarily need to be treated. You can at least perform active surveillance on them, where they're on the hamster wheel of just checking, rechecking PSAs, prostate exams, MRIs, et cetera. And if they ever had any worsening factors, like their PSA started really going up, or repeat biopsy did show worsening cancer, or the volume of cancer went up, they get off that hamster wheel. And now we open up the discussion again about treating for prostate cancer. while not missing our window of opportunity of cure. Okay. So first decision is, should it be treated? Second is, how do we treat it? Okay. How's active surveillance carried out at TCH and what is follow-up? I generally follow the active surveillance guidelines from, MSKCC, from, the white papers in the American Urologic Association, National Comprehensive Cancer Network. Essentially I counsel on risks and benefits. I do a PSA about every 4 to 6 months. If the PSA generally is below 10, I'll favor more the 6-month side of things. If it's over 10, I may do 3 to 6 months as opposed to 4 to 6 months, at least for that first year, just to make sure that I'm not catching a rapid rise in the PSA that would warrant treatment. I'll usually do a prostate exam in 6 to 12 months. By recommendations, we say 6 to 12 months. That's kind of printed in the literature. Now that we have MRI, I think an MRI of the prostate gives way better anatomic information about the prostate than a digital rectal exam. Do I do digital rectal exams? Absolutely. Are they important? I think absolutely. Are they the be all end all? No, I don't think so. I think that with the advent of MRI fusion biopsy, I think men do, our ability to find prostate cancers lurking in other places.
I'll put it back in the fridge.
The MRI is just phenomenal. So usually I'll do an MRI at 6 to 12 months. Generally, I do it at that 12-month mark because if you have, for instance, a Gleason 6 prostate cancer and your PSA is relatively stable, I think PSA is a good early indicator of worsening disease. And so generally speaking, I'm checking that PSA at 6 months and at that 12 months. But by recommendations, we are doing biopsies, that first biopsy at that 1 year mark. And generally, I will do an MRI fusion biopsy at that time. If the MRI does not show any specific lesion, then I will still do a biopsy, but it'll just be the standard 12-core or 24-core biopsy, depending on the size of the prostate at the time of the initial biopsy or at the time of that MRI. Okay.
Quick question. Quick question about the MRI. I'm drawing a blank on the score, but it's a 1 through 5 score. So how much weight do you place on that score? Whether it's because I've had the exact same MRI at one institution read as a 3, and then another radiologist at another institution read it as a 5.
Yes.
Same
very,
picture.
very, very good question. So first off, the numbers will go from 1 to 5. 1 and 2s, they will very seldomly even comment because the likelihood of any prostate cancer or clinically significant prostate cancer is super, super low. I look at 3s as a coin flip. Okay, really it's 50-50. So if you just had like a 5 millimeter Gleason, a 5 millimeter PIRADS 3 lesion, and nothing's really changed on your PSA, I don't think you necessarily need an MRI biopsy at that time. 4 is about 60 to 80%, concerning for a cancer. And then once you get to 5, about 80 to 90%. I think once we get to 100%, like to say, this is a PIRADS 5 lesion, you have prostate cancer, that's when this MRI will really skyrocket in terms of reducing overtreatment. But we're not there yet. And that's a very critical point to be made. The other point to be made here is that it's dependent on the radiologists and the type of MRI. So I'll hit the second point first, type of MRI. You got to have a 3 Tesla MRI, which is a strong magnetic field to get very pinpoint accuracy in terms of what the prostate looks like, okay? So a 3 Tesla MRI, let's say that we do at Christ Hospital, and let's say there's a man who has, for instance, claustrophobia and goes to ProScan and gets an open MRI, they're not the same. So even though they both had an MRI of the prostate, they are not the same. You have to have the right equipment to interpret and the right radiologist to interpret, the findings the right way. At Christ Hospital, we have only 3 or 4 radiologists that generally read MRIs of the pelvis, MRIs of the prostate. And that's important. You know, it would be nice to say every radiologist reads MRIs of the prostate. It's actually good to have only several. And the reason for that is they really look at a lot of them and they know what they're looking for. Okay. So oftentimes when I see an MRI lesion and I do a biopsy on that lesion, I'm actually looking at that data and I'm saying, how many of these scores of 3s or 4s or 5s on that MRI are actually correlating with the published data showing that it's a 50-50 for a PIRADS 3, 60-80% in a PIRADS 4, and nearing 80 to 90% in a PIRADS 5. And at Christ Hospital, I think we do a very good job sticking to that data that's published, as opposed to saying, hey, some radiologist called it a score of 5, and now I biopsied it 6 times and there's no cancer there, right? That's a very important thing. So getting the right test, meaning a 3 Tesla MRI, having a trained radiologist reading it, and then a proper urologist to interpret that data and know how to actually technically do the MRI fusion, I think are 3 of the most important things.
Sorry to interrupt again, but real quickly. So I had the same, I had this one film, one image, one MRI taken with the gold standard type of machine, read by 2 different radiologists, 2 different institutions. One is a 3, one as a 5, which is a huge difference, right? Yet all the other biopsies, everything else says active surveillance. The 5, at least to one physician, says you should have treatment because of the 5.
Yeah, so you bring up a good point there. You're not asking the question, but it's leading to a question. What does the 3, 4, and 5 mean in terms of grade of the prostate cancer? It's not making any statement as to what type of prostate cancer you have, just whether you have cancer or not. Does that make sense?
Yes.
So it's not a grading system like a Gleason score of 6, 7, 8, 9, or 10. It's just saying, what is the likelihood that this particular lesion is cancerous versus not cancerous? And that's where that 50%, 60, 80%, 80 to 90% come in, right? If a radiologist looks at a lesion and says, this is basically 50-50, whether you're going to find cancer here, which you would score as a 3, I may not need to do a biopsy. It's not telling me whether that's a Gleason 6, 7, 8, 9, or 10. Whereas a 5, for instance, if they say, look, it's probably cancer, I can biopsy that area and it shows up as a 6, or I could biopsy that area and it shows up at a 9. There's no correlation between the way the lesion looks and what the final pathology ends up being. So that's a very important point here to be made about what that grading system of MRI is utilized for.
Thank you.
Does that make sense? Yep.
Yes, absolutely. Thank you.
So factors affecting active surveillance. So, let's say I have you on active surveillance, we're monitoring the PSAs, we're doing all this. Factors that get you off the hamster wheel. And I kind of mentioned these a little bit earlier. The PSA velocity, how fast is that PSA going up in what amount of time? The Gleason upgrading. So let's say you started out at a Gleason 6 and now you have a Gleason 7. Or let's say, for instance, you had 1 core of Gleason 3 plus 4, and now a year later we biopsy and I find 3 biopsies of Gleason 4 plus 3. That's going to change some things because your risk stratification is no longer favorable intermediate, it's unfavorable intermediate. So there may be some high risk characteristics there. The volume of disease. Do you have 1 out of 12 cores positive? You have, a year later, you have 5 out of 12 cores positive. Generally speaking, if those are still a score 6 and the PSA is relatively stable, I don't take too much stock in that alone. But let's say it's 1 out of 12 cores of a Gleason 3 plus 4, and now I have 5 out of 12 of a Gleason 3 plus 4. Yeah, I think you need to have treatment. The certain genomic testings like Decipher, Prolaris, looking at the MRI changes, and then also patient anxiety, right? You may have a 1 out of 12 cores of Gleason 7, and I may talk to you and say, hey, you would be a good active surveillance candidate. And you're like, okay, I'm on it. And now 6 months later, you're like, I can't sleep at night worrying about my Gleason 7 prostate cancer. And then I generally will bring those men back, obviously, for active surveillance. And I'll tell them, hey, look, statistically, this probably won't cause you issues, but by the book, because you do have an intermediate risk prostate cancer, you probably, treatment would be warranted here. So active surveillance may be an option for someone with a score of 3+4, but not necessarily a recommendation. And who are not active or not candidates for active surveillance, what is your recommendation? Is there any form of focal treatment at Christ Hospital? So if not an active surveillance and treatment is indicated, I have a really long discussion regarding the pros and cons of treatment. I talk about radical prostatectomy versus radiation therapy. There's various forms. At Christ Hospital, we offer stereotactic brachytherapy, which is a really truncated form of radiation for a particular, you have to meet certain criteria in terms of urinary symptoms, prostate size, et cetera. We also have conventional external beam radiotherapy. There's other places that have proton beam therapy, cyberknife therapy, et cetera. Oftentimes, those forms of radiation therapy are not necessarily covered by insurance. They did some head-to-head trials of conventional radiation versus stuff like proton beam therapy with the idea that the side effect profile was less with proton beam therapy, or the risk of short and long-term side effects were were better. But that didn't really pan out. Those studies actually show that it's probably non-inferior, meaning proton beam therapy, cyberknife therapy probably aren't any worse than conventional radiation therapy. Now, there's a difference between probably not worse versus better, right? So that's something that we generally will talk about. Treatment depends on a variety of factors. I don't just look at age. Have I taken out prostates in men who are 72 years old? Sure. Do I generally take prostates out of men who are 81 years old? No, I don't. Right? Will you find a urologist that may do that? You very well may. So it depends really on the patient. It depends on the physician. It depends on having the right conversation and discussing all of the finer details and making that decision. If you go to someone who's just doing surgery and doesn't know about all the aspects of prostate cancer, you may go to them and they say, hey, you got cancer, it needs to come out. I don't practice medicine that way. I think you should have all the options at your disposal. And I think you have to look at a variety of factors. What is your surgical risk with regards to your medical issues? We touched on that a little bit earlier. Have you had multiple prior abdominal surgeries? Have you had peritoneal dialysis before? Have you had hernia repairs? Have you had bowel surgery? Have you had a gastric bypass surgery? Have you had your kidney removed? There can be scarring in the abdomen. So those things are extremely important to know prior to just saying, hey, you need surgery, because there are surgical risks. What is your preoperative urinary health? Looking at some of these questionnaires, is your urinary score low? Is it high? And that's going to factor into whether you're a good radiation candidate versus surgery candidate. If you're having all the urinary symptoms in the world and a big prostate, radiation may not be best for you, because that's only going to get worse over time. I look at things called the Johns Hopkins nomograms. And can you guys still see my screen? Are you guys still able to see my screen?
Yes.
You're good.
Yes.
So there's something, for instance, called these, Johns Hopkins. Can you see what I'm looking at right now?
Yes.
We're still seeing your slides.
Oh, you are? Okay. So let me. All right. Can you see this now?
Yes.
Okay. So this is called the Parton table data. So, for instance, if I say, oh, you have a PSA of 5.5, you have Gleason 3+4, and I diagnose this based on just the biopsy, I look at all these numbers. What are the numbers? What is the likelihood that your cancer is confined to the prostate, that it's potentially gone outside, has gone to the seminal vesicles or the lymph node? And here's a good point, for instance. Let's say we have Gleason score of 6, and I have a guy who has a PSA, for instance, of 12. So these are the original data. If it's a score of PSA less than 10, and now the PSA may be greater than 10, but look, the lymph node risk is still 1%, right? So I'm not just looking at PSA when I'm having those discussions. Let's say the gentleman's PSA is between 4 and 6, and the PSA, for instance, or the Gleason score is 6, compared to now the Gleason score is 7. The risk of lymph node disease is still only 1%, right? So even though, the Gleason score has gone from, let's say 6 to 7, the find is still pretty high. If you had 1 out of 12 cores, I may continue to keep an eye on that, right? And there's another set of data here called the Hahn tables, also out of Johns Hopkins, which gives me information on how men are going to do after prostatectomy. So what is the likelihood that their PSAs at 3 years, 5 years, 7 years, and 10 years, and I always look at 10-year data, what are the chances after removing the prostate that your PSA is going to be still undetectable? Well, if your Gleason score is 6, likelihood that if I remove your prostate, you're essentially cured of it is 95% at 10 years. I look at that in another way to say, hey, if your PSA or if your Gleason score is 6, and there's a 95% chance that you can be cured of this by 10 years, do you really need anything done about it, right? Whereas, for instance, if we go to a score of 7, yeah, this number drops down to about 90% chance that your PSA remains undetectable, 10% that the PSA starts to rise. And now let's say your PSA, you're on active surveillance, and your PSA was 7, and now it's gone up to 13. Well, now the numbers start to change a little bit, okay? So I use this as part of my counseling when I'm speaking, to my patients, and I actually have that data on there. Focal, couple other points. How important is it for you to know that the cancer is out pathologically? So some men are like, I want this cancer out. If it's already intermediate risk, I don't want to keep an eye on it. Let's get it out. And then we have a discussion about that. A risk assessment, if cancer returned after you remove the prostate, we know that radiation is possible in a salvage setting, meaning you can still try to get things in remission. If cancer returns after you've had radiation first, surgery often is not an option because there's a lot of scarring down in the pelvis, and surgery done on scarring leads to more scarring and more side effects. So, generally speaking, if you kind of resign yourself to hormone treatments, if you have radiation first, but the point here is that if you have an intermediate risk prostate cancer, for instance, the cure of surgery and radiation are the exact same. So the goal is to do a one and done, but some men are like, well, if there's a possibility that I needed something after, I don't want to resign myself to hormone shots after radiation, where other men are say, hey, look, if I have a 90% chance of being cured of this by 10 years, even with radiation, if it comes back, I'm fully prepared of getting hormone shots after that. So that's part of my counseling. Focal therapy at Christ Hospital. Do we currently have it? We don't. The issues I think related to it are the need for long-term data. It's not standard of care yet. Sometimes there's some insurance issues with getting coverage for it. And then the last is, how do you monitor cancer after focal treatment? Can you look at PSA? Can you, if, for instance, you had a 6 millimeter area on MRI and you had cryotherapy or ultrasound ablation, is MRI going to be a good tool to know that you've treated it successfully? Is PSA going to be a good tool to know you've successfully treated? It's a difficult sort of discussion there. And we don't have those hammered out yet. So even if you see a physician at an academic center that says, hey, let's talk about focal therapy, they're obligated to tell you those things, that It's not necessarily standard of care, but it can certainly be done. It's generally reserved for research studies as the research is coming out for it, or elderly men with very low volume disease and contraindications to other forms of standard therapy that still want treatment. Okay, so that's an important thing. For men who are, yep. Okay, for men who are candidates only for traditional curative treatment, meaning they're not candidates for active surveillance, or not good candidates for active surveillance, how does surgery stack up against radiation, which today offers high cure rates with fewer side effects than surgery? So I want to make a point here regarding this question I received. The main thing is fewer side effects. I would put a little caret here, and I would say fewer short-term side effects than surgery. Okay, we know that radiation has short-term and long-term side effects. Short-term, you may have some urgency and frequency, and maybe some burning and some fatigue, maybe rectal spasms, but you're not going to have the erectile dysfunction. You're not going to have leakage. You're not going to have significant obstructive symptoms. But then there's a lull for years, and then if you live long enough, you're going to have the long-term side effects that are difficult to deal with. Radiation cystitis, bleedy bladder, bleedy prostate, scar tissue in your prostate, pelvic pain, scarring, rectal spasms, rectal bleeding. You can have these. Does that happen to all men? Absolutely not. Would it happen to a man that I treated with radiation at age 55 compared to a man I treated with radiation at 70? For certain, in the 55-year-old guy, if he lives long enough. The 75-year-old guy may not have very many of those long-term symptoms. So that's extremely important. So the caveat here is, this question says, it makes it sound like radiation offers equal cure, but certain fewer side effects. You have to look at not only short-term, but also long-term side effects. So this is, for any of you that are interested in basic macroeconomics, this is actually a supply-demand curve, but I think it works really well for short-term, long-term side effects of radiation versus surgery. Think about price as side effects, and think about the x-axis as time. Okay. On the front end with surgery, the price is going to be high, right? You're going to have maybe some incontinence, some convalescence time period. You're going to have a catheter for a week. You're going to have erectile issues. And over time, that's actually going to improve. Okay. The cost to you is actually going to go down. With radiation, you may not have very many symptoms on the front end, but flash forward 15, 20 years, you're going to have all those symptoms that I discussed. So now, is it as sharp of a decline, and is it as sharp of a rise as this? No. Imagine this being somewhere way out here and this being something way out here. Okay. But I use this to kind of illustrate that radiation, you may not have as many side effects on the front end, but maybe on the back end. Surgery, you may have more side effects on the front end, but not on the back end. Okay. So you do have to look at short and long-term side effects. How is a treatment decision made at Christ Hospital? Are patients made fully aware of the chance of cure versus serious side effects of surgery? Radiation with where are my other two slides? 1 second. Must have skipped over them. Sorry, give me just a second. Can you all see this? No, that's the active surveillance one. Sorry, give me just 1 second. I'm just finding. Okay, so let me share something new with you guys. Okay, can you guys see this? Are you guys able to see this? I know it's small.
Yeah, we can see it, but it's hard to read.
Yeah, it's hard to read. So this, I just use this as an illustration to show you what my office note looks like when I counsel men for prostate cancer treatment. And the reason I bring this up is I'm looking at a variety of factors when I'm discussing. Okay, so if you look at the top here, I'm looking at the stage, I'm looking at the risk stratification, the Gleason score, the ultrasound prostate volume or an MRI volume. Have you had any abdominal surgeries? What is your Decipher Prolaris score? I'm looking at that Parton table data, the Hahn nomogram data. I'm looking at all your PSAs. I'm looking at your questionnaires. I'm looking at your risk factors in terms of age, being African American, having family history. I'm discussing all of these factors in treatment with you. Do you have erections? Do you have a median lobe of the prostate that may make surgery a little bit harder, or radiation a little bit harder? And then I talk about the various different treatment options, and we kind of go line by line about those. And then I talk about primarily surgery versus radiation versus active surveillance versus hormone therapy as it relates to each man. So my point in illustrating this is just to show you that when I see a man and I'm talking, a man with prostate cancer, and we're talking about the difficult diagnosis in the first place, we're hitting on every single one of these issues during our discussion. So again, as I mentioned earlier, every man is different. Okay. So can you all see this? Am I back to my PowerPoint presentation?
Yeah.
I am. Okay. So the last question is, that I got is, 69-year-old, actually two questions. I don't want to forget that other one that we were given, but a 69-year-old man has Gleason 3+4 prostate cancer with only 10 to 20% grade 4. Genetic tests on, sorry, I kind of scribbled this fast, so sorry for the typos. Genetic tests on the biopsy prostate cancer showed low risk. PSA is 10 and was 4 some 7 years ago before the current PSA. Would you treat him, and how, or advise him to do nothing because of the odds that he'll die from something other than prostate cancer? So this is a very good case vignette after us having talked about all the different factors that I looked at or that we would have discussed. So on the one hand, you've got a 69-year-old gentleman. On the other hand, you also have a guy with Gleason 7 disease. He's got 10 to 20% of the grade group 4 on there. And his PSA is rising. So a couple things that I would want to know is, what are the PSAs doing during that time? Number two, how many cores of Gleason 3+4 were there compared to, were there any 4+3? Were there any 3+3 in there? What is his overall health? What does he want out of it? Is this the first biopsy he's had, or is this subsequent biopsies that he's had? And what does he want out of it, right? So when I counsel men on this, I say, hey, look, you have a favorable intermediate prostate cancer where the cure rates of radiation and surgery are the same, okay? It's all about what side effects you're willing to put up with. So I'll do a history about, has he had abdominal surgeries and what's his overall health, perception of his overall health, all the things we talked about earlier. And I'll say, on the one hand, radiation has some short-term side effect, long-term side effects. On the other hand, surgery has more short-term and less long-term side effects. But I tell all men with surgery, you will have leakage on the front end, which will improve. You will have erectile issues, which will and should improve. You just may need an erectile aid. The other thing that I'll counsel this man on is, how important is it to you at age 69 to have it out, know how the prostate cancer has been removed, the lymph nodes are negative, and that your PSA comes to an undetectable level. If he's like, hey, the cure rates are the same for both and I don't want surgery, I think radiation is a perfectly good option for him, provided the prostate is within a reasonable size and he's not having very many urinary symptoms. If he has urgency, frequency, weak stream, intermittency, waking up 4 times a night, has a large median lobe of his prostate, and his prostate volume's like 100, then I say, if you're having a lot of urinary symptoms and you have a big prostate, removal of the prostate may serve you better, because to put that much radiation in a prostate that big, you may not get it all, or you may have every symptom in the world during treatment, but also down the line. Okay. So with regards to surgery, I would say, if you had surgery, like if he had settled on surgery, one thing we have in our back pocket, for instance, if prostate cancer recurs 6-7 years down the line, is we have radiation in our back pocket. So if the PSA, let's say 7, 8, 10 years down the line, after being undetectable, goes to 0.1, and then it goes to 0.2, and then it goes to 0.4, then it goes to 0.6 or 0.8. We can always do radiation to the area where the prostate used to be, because statistically, the recurrent prostate cancer cells are going to be in and around that area. Okay, particularly if the PSA is rising slowly. Okay, if the PSA is rising very quickly, then oftentimes I'll do some imaging studies just to make sure that there's no prostate cancer that's already sprouted in the lymph nodes or bone or something like that. Okay, so with surgery, you have radiation in your back pocket. With radiation, you can't really do surgery after it because of the scarring issues. But at the same token, you have to be kind of okay if the PSA rises significantly to start on hormone shots, which have their own sort of side effects. So that's how I would counsel this man. If he has a good performance status, he's otherwise healthy, takes care of himself, active, motivated, compliant, then I would say he'd be a good surgical candidate, provided he understood the risks and benefits. Okay. Does that make sense? Yeah. Okay. So I have another question here. It says, regarding prostate cancer testing, what is your opinion on urine-based? Yeah. So this was the other question. Is this some? So let me read the question. Regarding prostate cancer testing, what is your opinion on urine-based testing and liquid biopsies? Is this something that you are currently using, and on what type of patients? Do you know if these tests are covered by Medicare? So let me answer the last question first. Are they covered by Medicare? Some of them are, some of them are not. Guidelines and insurance companies are very slow to catch up with guidelines, and guidelines are slow to catch up with data. So the way it generally works is you've got a lot of data, flash forward a couple of years, now you have guidelines, flash forward a year or two, and now you have insurance covering it for it, insurance coverage. It all depends on the particular type of test. I do not have a lot of experience with the liquid biopsies. Urine-based testing, there are a few new tests out here. I do generally use MRI, so it's more in order to test focally where the prostate cancer is, and then if there's cancer, okay, and it's a lower intermediate risk cancer, I'll either do a Decipher test or a Prolaris test. So those are those genetic tests. Those I think I use more for prognostic information and figuring out if someone's on the fence of what type of treatment they want, or more importantly, do they want treatment or not. I don't have as much, actually, I don't have much experience at all, really, with the liquid biopsies. There's, again, new testing coming out all the time. I just can't really speak to the sensitivity and specificity of those tests, as I don't use them very often, but certainly something that's coming down the pike, and we'll certainly be looking at that. So it's a little bit of a dodge for part of that, but I want to be completely open and honest with you guys regarding that. And then Shannon had another email. I have a medical prostatectomy on nerves. The PSA was 9.89 at the time of biopsy, or it's 9.89. Biopsy was 12 out of, I'm assuming 12 out of 12 cores positive. It was positive with 8 and 9 Gleason score, stage 2B. So After surgery, it was found to be 3B. Just for sort of a knowledge of what 3B means, what that means is after the prostate was removed, the prostate cancer had involved the seminal vesicles. Okay, so that's where we get to 3B. Not sure if all the cancer was out. Am I still treatable with long-term survival? I am 52 years old. Excellent question.
Wow.
Excellent question.
Poor guy.
Number one, you're young. So I think that throwing the kitchen sink is the most important thing because we have radiation in our back pocket if we need it. Now, I would assume that perhaps you had a bone scan, CT scan that did not necessarily show any cancer in the lymph nodes or bone. And I would most certainly think that you would have had a lymph node dissection here. Okay. So, it depends on, number one, were the lymph nodes positive or negative. If the lymph nodes were negative, it depends on whether the margin status was negative. Okay. What is margin status? Well, when we remove a prostate, we want to stay wide on the prostate when we have Gleason 9 prostate cancers that have high volume disease. And we want to know if cancer was within the last cell layer that we took out. If that margin was negative, okay, meaning all the cancer was within the cell layer that I removed, right? Then what I would do is about 6 to 8 weeks down the line, I would check a PSA. And if your PSA went to an undetectable level, I would monitor it every 3 months until there was a reason to give radiation. So if the PSA went down to less than 0.1, 6 to 8 weeks down the line, and it stayed at less than 0.1, less than 0.1, less than 0.1, then I think we monitor you. And if at any point it went from 0.1 to 0.2 to 0.4, boom, I would go ahead and hit with radiation on top of that. But not that right after surgery, because you're only 52 years old. So we want to make sure that you regain your continence ability, your ability to hold on to urine as much as possible before doing that. Now, if the lymph nodes were negative and if the margins were negative, then to answer your question, am I treatable with long-term survival? Absolutely, I think you are. But I also think that we have to monitor you a lot more closely. Number one, because you're young. Number two, because you did have a high Gleason score and a higher stage disease on pathologic, on the pathology specimen. So what would be important to know is what was the margin status? What is a lymph node sort of status? So those would be very important. I take it that the pathology may still be pending. And so those are going to be key factors in figuring out the answer to that question, which is, am I treatable? Am I still treatable with long-term survival? Even if the lymph nodes are positive, there are still treatments available that can prolong life, but it all depends on how many lymph nodes are positive. Did you have a bone scan showing possible abnormalities? Oftentimes, if the lymph nodes are positive, now there's something called a pylorified PET scan, where you can actually do a PET scan and see were there any bony areas or other lymph node areas that were positive that weren't shown on the CAT scan or bone scan. So that is kind of the newest, latest, greatest scan now for looking for advanced prostate cancer in high-risk patients. And we will soon be getting that at Christ Hospital. We're certainly ordering that test right now, but we're having it done at either Mercy or UC or St. E's. But we will be having that very soon, as I've been assured by the Prostate Cancer Committee. So, yeah, that's a very good question. I feel for you. That's a very difficult thing to go through. I'm really glad that you're part of the prostate cancer support group, because these are your cohorts. These are the men that are also going to help you through it along with family and friends. But the good news here, you screened, you caught it, right? Imagine if at age 52 you had no screening, you know? This goes back to those first several questions that we had. If you had no screening, I don't know where you'd be at 56, 57, 58. I would not be able to answer that question, you know, because if you had a Gleason 9 and you were 58 and you were diagnosed, chances are by that point you probably already have lymph node disease. If you had untreated